I'd like to welcome you to this series that we're calling Plug the Hole, Leverage Telehealth to Stop System Leakage. This is really going to be about a telehealth communication tool that will help bring value to your health system and decrease overall cost to your health system. First, I'd like to introduce myself. My name is Forrest Winslow. I'm currently working for a company called Pulsara, where I'm the Northeast Regional Sales Manager. Previously to my role here in the past 2 years, I was a full-time firefighter paramedic where I did a lot of quality initiatives on a state, local, and department level in Virginia. And then I also had a role where I was a registered nurse in the emergency department and also in the cardiac cath lab. I spent the last few years really focusing on quality and improving care and discovered Pulsara, the company that I currently work for, by utilizing the system and bringing it to our healthcare system along with the department in which I worked. The point of this presentation is to have you do a little exercise where you're evaluating your organization or health system in which you work for. And we're going to try to cover 3 objectives where we're going to be looking at proactive steps you can take to minimize system leakage by leveraging telehealth communication, streamlining your communication that hopefully will lead to fewer errors, more efficient care, decreased length of stay, and minimizing readmissions to your facility. Creating an automatic referral pattern. By doing this, you can increase or build stronger relationships with those surrounding facilities that either send or receive patients from your organization, and also with those that are received from EMS, making you the preferred referral partner. So before we get started, I'd like for you to take out a piece of paper, and really over the next 30 to 40 minutes, we're going to be looking at a few things where I'm going to ask you to record information on a piece of paper so you can refer back to it after this conference. And first, I'd like for you to kind of think about the organization that you work for or the system. I want you to answer if your hospital organization is more of a spoke or hub facility. Spoke facilities are those facilities that have less comprehensive services, and hub facilities are ones that get more patients that need greater or higher levels of care. And in some cases, it is appropriate to say both. In a lot of hospitals will potentially have a cardiac cath lab where they receive heart attacks and STEMIs, and they can do definitive care, but they may not have the ability to do comprehensive care around thrombectomies for strokes or high-level burn or trauma care. So in those cases, you would be a spoke in some scenarios where you're referring out patients, but in other areas, you would be that receiving facility or that hub. I think it's important for us to cover a few definitions around some of the topics I'm going to be talking about. The first thing is system leakage. When we look at hospitals, they are quite often in organizations are losing money to other surrounding hospitals, but there are also programs that are causing you to lose revenue. One of those programs potentially could be the hospital readmission reduction program. CMS set up this program nearly 9 years ago where they were trying to decrease excessive readmissions, and that began in October of 2012. And they were really looking at 30-day risk standardized unplanned readmission around 6 diagnoses, and those diagnoses were acute myocardial infarction or heart attack, chronic obstructive pulmonary disease or COPD, heart failure, pneumonia, coronary artery bypass surgeries, and then other orthopedic surgeries like hip and total knee replacements. Like I said, this was the 9th year in which it started, and in this 2021 time period, the actual fiscal year of this period, I'm going to look at some of the impacts that it may be having with your system or surrounding hospital systems. So this year, there were 2,545 hospitals that were penalized. The data is that the data that drove the penalties was from July 2016 to June of 2019, they compared national averages for each one of those conditions that we previously covered. And then it was reported by Kaiser Health News that 83% of the 3,080 hospitals received the penalty, which is that 2545 above. 3% is the maximum cut in payment for each Medicare case, and there were 39 hospitals that did receive that maximum penalty, and on average there was a 0.69% penalty, which could really equate to a significant amount of money when you look at how many patients are being treated or billed under Medicare. There were 613 hospitals that had a penalty of 1% or more. So how are we defining system leakage when we're talking here today? We're using a CMS definition where leakage represents the total Medicare payment for patients who receive care at a particular hospital that were also treated at one or more hospitals in the same given calendar year. So I asked you earlier if you were a receiving or a referring hospital, a spoke or a hub. And in that scenario, I want you to also think about potentially who you are referring or receiving patients from. So on that piece of paper, I'd like for you to make 3 columns. And in the top of the column, I'd like for you to say who, how often, and how much in those 3 columns. I want you to now take and think about the surrounding facilities that send you patients or that you send patients to. Also, this can be a best guess, but how often do you think this activity is occurring? And maybe even denote what service lines are sending them. Trauma versus cardiovascular versus neurovascular. And then how much is that costing because you're sending those patients out? Or how much are you getting because you are bringing those patients into your facility if you're that hub facility? So now that you've recorded that, we're going to try to define or identify what the problem is around poor communication. Really, when we as a company, what we strive to do is increase or improve the overall communication around a patient's care event. And that is really one of the biggest drivers in helping a patient as far as preventing miscommunication that leads to greater errors. So I want to kind of go through a couple of things to kind of say what the real problem is with poor communication and what it leads to. So we know that it decreases the quality and quite often the patient's outcomes because of errors or mistakes that occur. The patient's experience is far worse because they have these complications. That equates to a decrease in their overall satisfaction. There is an increased cost of healthcare because sometimes this allows the patient to have to stay longer because of these complications. And overall, when you look at your clinical staff, and there's an increase in burnout and stress to these clinicians. So with that being said, write down who or what roles or departments in your hospital seem to have a high turnover rate. And if you don't know that, maybe that's something you can go back and discover once you're back at your facility. How often are they having to replace staff members? So what is the rate of replacement? And how much is that costing that department or your facility overall? So there was also a study that Joint Commission did where they looked at transforming healthcare, and they discovered that 80% of medical mistakes are caused by healthcare miscommunication. We know that increases errors, causes potentially patient injury, and also patient death in some extreme cases. And that really leads to an increased liability for a hospital. So accepted practice is that outcomes are usually better when communication is better. So what we know that poor communication makes your system less efficient. It causes increased complications. Quite often, it will increase the overall length of stay because of these complications. And then sometimes the patient will have to be even readmitted because of those issues. The next problem I'd like to talk about is how much revenue is your health system losing, but not by not being that site or preferred referral partner. So earlier we talked about who's sending you these patients, where are you getting them from, where are you sending your patients if you are that referring site, and then what does that look like as far as a strategy and relationship that you've established with referral centers. So when we look around patient communication issues, when we're talking about preferred referral sites or preferred referral partners, there's really a decrease in patient satisfaction, especially if the patient has to be sent out of your facility unnecessarily, or it's perceived that they were sent there unnecessarily. And then there's also a potential for that increased system leakage, where you're actually having to admit someone to another hospital for the same disease process. And then in many cases, what I was saying earlier is these inappropriate transfers in some cases could be prevented if you utilize the telehealth component to actually evaluate them by that receiving facility or provider to potentially prevent them from even leaving the primary site of treatment. Currently, we know that a lot of communication within healthcare is very siloed. And what I mean by that is that right now, when you look at the way EMS communicates with potentially an ER physician or a nurse, we have developed modes or methods of doing that. And that can be through radios, faxing different health records, or EKGs through transmission systems. But when you think about these methods that we've chosen to communicate across, they're usually a very one-to-one style communication where that person now has to pass it on to another team member. And there's significant degradation in a lot of these processes because staff members are overworked, overstressed, and they forget to record a certain important component that later could lead to that miscommunication or that patient being injured or actually not having a great outcome or decreased efficiency as far as time to ultimate treatment. And that's the same for when you look at our referral process, where we're trying to get a patient from one facility to the other, or even just getting interventional teams into the facility with accurate information to be able to provide and strategize care in a very time-sensitive emergency, quite often when you're responding to interventional teams. So just another way of looking at that, when you kind of look at all the components of healthcare communication today, it really could go from the first responder to that ambulance crew, to the hospital, to a referring ambulance that sends a patient to that transferring hospital. You involve transfer centers or comm centers that actually have to pass the information along. And all of these red lines really represent all of that archaic communication. And so what I'm going to show you in a bit is how this potentially could be significantly better if you had a platform where you broke down these silos and you brought everybody into one communication channel and looked at the patient's journey from the beginning of their medical emergency or medical event all the way to definitive care when everything was mitigated. So what can a telehealth communication platform do for your bottom line at your facility? So number one, it potentially could eliminate cost. It could reduce your overall cost. It could help you recoup revenue or recoup costs, and then continue to grow revenue. So I'm going to walk through these things and actually show you some examples of how leveraging a telehealth communication platform could potentially do all of these things for your system. So when we're talking about eliminating cost, I want you to pause and think about different platforms that are being utilized in your facility right now. And I'll allow a little time after this slide as we walk through some of the examples, and you'll probably have more than what I'm coming up with. But number one, more than likely, you have some type of EKG transmission tool for EMS providers to send EKGs into your hospital to be evaluated by physicians or staff members to determine if this truly is a STEMI or not, or a heart attack that needs to go to the cath lab. We have a lot of our current clients at Pulsara that have reported that they're paying as much as, or more, sometimes more than $12,000 a year to actually have a system like this. So it is an area in which you're spending money for something that potentially could be part of another telehealth or another communication platform. There's also a lot of facilities will have false activation or overactivation of their interventional teams, such as the cardiac cath lab and your neurovascular teams, when these patients truly do not meet metric or are not someone that is having that style emergency, where if a telehealth communication tool was leveraged, where you can have a provider look at that EKG or look at that patient at the other referring site or the one in the field, you potentially could stop patients or stop your responders, such as your interventional teams, from actually being activated on that emergency, decreasing their burnout, and also decreasing the overall cost for them coming in, opening up supplies that potentially are costly, and also FTEs as far as paying them for the service hours in which they're on call or responding in. The other thing is a lot of people have very expensive telehealth hardware and software systems that sometimes are not fully utilized, or they're only being utilized for a very small scope of practice. And then just think about your overall vendor profile of where you're using technology in your facility and where you could eliminate it if a system could transmit EKGs, have a telehealth component, have the ability to send messages through HIPAA compliant text messages, and also phone calls and activations of interventional teams. So we're going to do a little drill down, and this is where I'm going to ask you to record some of that information. So I'm going to, once again, we're going to go back to the who. And so under this one, I want you to record under that column the products, the services that you're utilizing currently. And then I think one of the other things that you really need to look at is how often are you utilizing the system, and then how much is it costing you, either for each annual subscription or for each episode of care. And they're probably going to be individual, depending on if you're looking at a telehealth software piece of equipment or software solution, and then comparing that to some type of system like an EKG transmission system. But the other thing is look at that false activation rate that you're having for these interventional teams. If you don't know this, it's okay to go back to your facility and inquire about it as well. So we were talking about reducing cost. So what are some ways you could reduce cost in the overall bottom line, or increase the bottom line of your facility? So we know that research demonstrates overall time to treatment, especially around your time-sensitive emergencies, the patient has a much better outcome. Mortality is usually less, morbidity is less. Just as an example, we know for any heart attack or STEMI patient that goes beyond 80 minutes from the onset of symptoms or from first medical contact to definitive care, there's a exponential increase in mortality after that 80-minute period. So we know by decreasing treatment times, there's a reduction of complications. And a lot of this could be around, there's a reduction of the overall injury size to that tissue area. If it's a heart attack, we're talking about the cardiac muscle itself, the heart. So there's less chances of heart failure, less chances of rhythm disturbance where the person may or may not go into cardiac arrest. For the brain or neurovascular stuff, we're talking about a decrease in the amount of deficit the person will have and what their recovery period looks like. All of these things usually equate to a reduction in length of stay. Quite often it will reduce their readmission because they don't have these complications. And then because their length of stay and readmissions are less, it reduces the cost per admission to your facility, making you more efficient and also reducing your overall cost to the health system. And so just as an example, one of our clients reported out to us is that because of the reduced treatment time, they estimated that in their heart attack service line, they saved about $12,000 annually. And then for stroke, it was upward of $60,000 savings. So, how can we grow revenue around a telehealth solution? Well, we know that we will increase efficiency quite often by being able to provide care for more patients at a faster pace, which will increase the rate in which you can accept patients. An example of that is that if you have a arriving heart attack victim and you can pre-plan for their treatment pathway and then make sure that their efficient times are less than that 90-minute FMC to device time or 60 minutes from door to device time. You really overall are shaving minutes off of every patient, making you more readily available to then either do that scheduled case, or if you have another arriving STEMI at the same time, you potentially could bring that patient to the lab, where in other cases you would have to refer them away or do another care strategy, which may be less profitable to your facility. The other thing is that a lot of times when you are technology driven and users have a better experience, you're going to become that preferred referral site, preferred for both EMS for being that destination where they want to take their patients when they have an either or choice of coming to you or your competitor. And then also for your competitors or facilities around you is being that easy button or that preferred referral organization where your tools and your telehealth communication tools will actually make it easier for them to accept that patient or have you accept that patient from them, and making their treatment times more efficient at their facility. The other thing that really helps around having good communication and leveraging a tool like a telehealth communication platform is that because you will have more efficient care, there's usually a lot less dwell time or time within the emergency department. And that makes that throughput of your emergency department patients be better, and their discharge rates are faster or getting them out, or their admission rates into the hospital or rate of getting them admitted is faster because they're having to be less bogged down by trying to maintain a critical patient that is awaiting the arrival of an interventional team, such as your Cath lab or neurovascular team or trauma teams to care for the patient. So I'd like to kind of drive you through what our company does and how we are one example of a telehealth communication system that was created and dreamed up by our founder and CEO, Dr. Woodson. And he really believes in the concept of it's about people. And what he means by that, it's not necessarily always about the patient, which we know we want to be patient-centered, but it's also about the care providers and making their care of their ability to care for patients a more pleasant experience, where they feel good about what they did when they left for the day because they provided the best care they could without a great deal of frustration. So he was a practicing physician in an emergency department where he saw heart attack victims, septic patients, stroke patients sitting there, and he could order a pizza or book travel halfway around the world, but he couldn't communicate about a patient on a telephone or smartphone device in his pocket because of all the HIPAA rules and regulations around that communication structure. So he would have to call a one call center or page on-call physicians who then would have to call him back, causing him to be pulled from the bedside of another patient that he was caring for to answer a phone. And he says, there's got to be a better way of doing this. And so he came up with the concept of utilizing mobile technology to activate interventional teams and communicate seamlessly across what we call the Pulsara Red Line, where we are looking at these silos of communication, breaking them down. We create a unified patient channel, build teams around that emergency. That could be a pulmonary ambulance response team. That could be your high-risk OB team. It could be that STEMI team or stroke team that I talked about. And then we communicate on that patient channel until the emergency is mitigated. This also has the ability to pull in data from different monitors, different imaging systems, and then also to be able to export this data into your registries that a lot of your quality staff are looking at. And when we talk about improved communication, we're really talking about driving down those treatment times to definitive care and then really helping those interventional teams coordinate care at a much faster pace to prevent that patient from falling out of metrics, which will then impact your reimbursement rates as well. This can be for all service lines. So when you are looking at a platform, it is important to try to decrease that vendor profile. We don't want some to be able to only be utilized by trauma or stroke. You need to be looking at a product that can be used across all service lines, all departments, all parts of the hospital, so you're more efficient in providing care. And there's one way of everybody doing business, especially when it comes to your ED staff that has to deal with all patient types and your EMS providers that are bringing them all patient types. So one of the other things that you really want to make sure of is that when you're looking at a system, that you want to make sure that it's not only for those inbound EMS patients or ED patients that walk in that are having time-sensitive emergencies, but it's also for that patient that's up on the floor. So when you have a patient on the floor that has a heart attack or a stroke, quite often, because the care providers are not the same people that are used to doing this process on a frequent basis, the care is less efficient. And what I mean by that is if you ask an emergency department person to activate a STEMI process or stroke process or sepsis process, they really are going to know that process because they do it every day. Where the floor nurse and the hospitalist that's evaluating that heart attack victim, it's not part of their daily routine to do this, nor is it to activate these interventional teams or know the call schedules. With a system like Pulsara, this will allow them to communicate through a tool that will show them who's on call. They'll be able to activate, consult with that specialist to be able to make those decisions. And once you activate the interventional teams, their alerting structure is the same no matter if it was an EMS arriving patient, an ED walk-in patient, or that inpatient. The only difference is who starts the case and then the room number, where the patient's coming from. So I think we should kind of look at this improved communication and what it really does for that patient. We're improving communication, not just to ease up staff or better the staff experience, but also increase that patient's safety, trying to reduce a lot of those complications that happen because care providers didn't know a specific thing about their care that was provided prior to them getting into a different treatment area. And then overall increasing the patient satisfaction from just having a better experience. The other thing that you really should be leveraging a telehealth communication tool is to decrease those inappropriate transfers. So if you are that spoke facility that has to send out an injury or trauma patient or stroke patient for comprehensive care, wouldn't it be nice to be able to pick up a low-cost device such as a smartphone, iPad, and then start a telehealth conference with a specialist at the other facility to do that doctor-to-doctor consultation and be able to say, yes, this patient needs to come to us, or no, they don't. And it would be better for them to stay at your facility because we have ruled them out as someone that could potentially benefit from their services. What that does for the patient is they get to stay typically closer to home. Their family would be closer to them for visiting. And then you keep that patient as far as revenues, and the comprehensive center that may be overwhelmed with a volume of patients isn't getting patients they don't necessarily need or can't necessarily do anything in addition than what you can at the referring site. And just on the opposite side of that coin, if you are that receiving facility, the benefits is that you will streamline the transfer process for all of those sites around you. And earlier I had you write down who is sending you patients or where are you sending patients. Think about leveraging those relationships and creating an easy button for them to push to bring in patients to you. And I know you know your areas of your geography better than I would, obviously, and you're coming from diverse locations. But think about when a smaller hospital that potentially is sending you a patient has the choice to either send it to you or your competitor that's in another geographical region, but it's an either or choice. What if they had a platform that was something like this telehealth communication tool, such as Pulsara, where they could have this transfer and consult as part of their process? And once it becomes a part of their process, then they say, okay, this is our preferred process. This is where the person's going to get the more efficient care. And this is an easier functional system for us to communicate with that other facility. And then you truly do become that preferred referral site for those organizations that have an either or choice when you're really looking at increasing those patients that need comprehensive services that typically are your higher payers when it comes to reimbursement. It also allows you to use, you also want to be looking at a telehealth tool that can be utilized across different health systems, not just necessarily, from hospital to hospital, but even those EMS to emergency department communications that need to occur. There's sometimes video can play a big part, or even just simply a picture of a scene or a picture of the patient or their med list or their driver's license or their um, ID cards to get them pre-arrived to make that patient's care go much faster. And then, like I talked about, that consult and transfer, really making you the preferred referral pattern and creating an easy process for your partners in the community to refer you patients. You definitely want to be that preferred referral partner. So this is what it looks like for an EMS provider to start a case within our system. It takes about 45 to 60 seconds. And the nice thing about it, once they put this information into the patient channel, it is there for all teams within your hospital to consume, be it the emergency department or the interventional staff. And this example that we're showing you is a stroke right now. They're simply going to put in there's some simple demographics, the name of the facility they're transferring to, a stroke score, an AccuCheck, a last name well, potentially add an audio clip, which would be the replacement of a phone call or a radio report coming in. They can add images to the event that we spoke of earlier, where you're pulling in that the driver's license, the ID, med list, or any of the important information around the patient to really start the patient's journey and have all of the information at your hand for the interventional teams itself. So none of the pictures go to the camera roll, none of the audio clips are saved directly on the device itself. They're all in the cloud. And then by a touch of a button, you can activate your interventional teams. This could be an ER nurse or an ER physician that says, yes, this looks like a STEMI. It looks like a stroke. It is a level 2 trauma. We really need to activate teams quickly. And just as I just showed you, them hitting activate then pushes it to the entire care team that needs to be activated at this point. And all of these things are customizable. EMS is then given a push notification to say, yes, that patient has been received by the hospital and we've acknowledged that we received your communication. And at that point, those two entities are open to communicate with one another. And once the interventional teams are brought into the case, they're also able to communicate across the entire platform. And like I said, all of these workflows can be customizable. And so I talked about the live video that we have, audio clips, integration with different monitoring systems, different imaging systems, and then accurate ETAs based on GPS for you to coordinate care. We recently had one of our cardiologists at one of our facilities, who is in the mountains of Virginia, tell a story about how they had a patient on the table. And it's a smaller hospital that only has one lab for their cardiac cath lab. And because of earlier activation, they knew they had time to finish that case that was on the table and coordinate some of their other team members to be ready to receive the STEMI when it arrived or the heart attack when it arrived. And so they really had an awesome door to device time on that patient. And they were also able to have enough information to say, yes, that patient that's currently on our table, we have time to take care of it. So they also have, or take care of them. So they also have a very good experience where a lot of times, if you don't know an accurate ETA of that patient, they may have decided to abort that case, making that patient feel less important and also delaying their care as far as being discharged that later that day if it was an outpatient procedure. I'm going to wrap up by saying I don't think we can underestimate the power of feedback to our entire care team, and the communication tool like Pulsara can definitely engage not only your hospital staff, but also the EMS providers that brought you the patient. Quite often, even your emergency department staff, once an emergency is mitigated, they really don't have time, or they're restricted from going back into the chart to reviewing what the definitive decision was. But because they were part of the communication chain about this patient, they can also be alerted once the case is closed to get that information. And all of those time metrics that are captured through a system, all of the quality of the video calls, all the images that are captured throughout the system, and the audit trail or timeline that's built around communication. All the meanwhile, while you're tracking all of your communications through a system like this, you're also capturing critical time and data points. Pulling out these metrics for your registries is a very important process, especially around cardiovascular, neurovascular, your sepsis process, and reporting them to become that certified, or to report to that certifying body that your accreditation process goes through. It is super simple to capture this information. It can be in a PDF version, HTML version, and also a common separate values worksheet. And I think that's one of the biggest benefits to having a comprehensive tool that communicates through the patient's journey, is that you're also tracking all the events, all the times, and then in a nice usable format can be exported out of the platform that not only just gives you the discrete data points, but also does auto calculation of that information, which is a huge time saver for your quality staff at the different hospitals. If you have any questions or would like to see more about the system, feel free to reach out to our company at pulsara.com. You can reach out to me personally. My email is Forrest with 2 R's at pulsara.com. And I'd be happy to walk you through some more detailed information about the system, but also discuss with you what it could potentially mean at your facility as far as decreasing revenue loss or potentially increasing your patient experience through a platform like Pulsara. All right, thank you again, and I enjoyed doing the session for you.